Hello everyone. So today I'll be discussing the topic GIST, gastrointestinal stromal tumor. So it's a stromal tumor. That means it's a mesenchymal tumor. What are the types of tumors? In the stomach, we have epithelial tumor. Epithelial tumor, the benign ones are adenoma and polyp. And malignant epithelial tumor is adenocarcinoma. So the first category is epithelial tumors, the cells which line the stomach, epithelium. From there, if a tumor arises, it is either a adenoma or polyp, that's a benign category. Adenocarcinoma is the malignant one. Then the mesenchymal tumors, that is this uh, mesenchymal tissue that supports the epithelium, like the gist. Then leiomyoma or leiomyosarcoma, it's a mesenchymal tumor which arises from the smooth muscle cells of the stomach. Desmoid tumor. Desmoid tumor arises from uh, the aponeurosis that covers the muscle. So it's a musculo-aponeurotic structure origin tumor. Okay, right. So epithelial tumors, the classification: adenoma and polyp, benign category; adenocarcinoma, malignant category. Mesenchymal tumors: gist, leiomyoma, leiomyosarcoma, and desmoid tumor. These are mesenchymal tumors. Then we have neuroendocrinal tumors. Example is carcinoid tumor, and lymphoid tumors. Example is gastric lymphoma. So epithelial tumors, mesenchymal tumors, uh, neuroendocrinal tumors, and lymphoid tumors. This is the classification. Next is the origin. So they origin from the interstitial cells of Cajal of stomach. Most common site is stomach, followed by small intestine. So stomach followed by small intestine. In the stomach, it arises from the interstitial cells of Cajal, which is the pacemaker cell. Now, gist in stomach has better prognosis than other sites. The most sensitive marker, immunohistochemistry marker of this condition is KIT or CD117. See, KIT produces the KIT gene, it produces tyrosine kinase receptor. KIT gene produces tyrosine kinase receptor, which is known as CD117. Now, other than the KIT gene mutation, which is the most sensitive marker for this condition, the most sensitive immunohistochemistry marker is CD117 or c-KIT, and most specific is DOG1. DOG1 is discovered on gist. Discovered on gist. Other than that, we have CD34. 70% cases में पॉजिटिव होता है. Okay. So KIT, DOG1, CD34. Desmin and S100 are negative. They are positive when the tumor is of muscle origin. Because it's not a muscle origin tumor, it's a mesenchymal tumor, but it is a non-muscle origin mesenchymal tumor. So so Desmin and S100 is negative. Where Desmin is positive, it is positive in leiomyoma, leiomyosarcoma, rhabdomyoma, rhabdomyosarcoma. Leiomyoma, leiomyosarcoma, rhabdomyoma, rhabdomyosarcoma. Desmin S100 is positive. Actually, mainly Desmin is positive in this condition. Desmin is the marker of muscle origin. S100 is marker of neural crest origin. S100 is marker involved in the neural crest origin tumors like melanoma, like schwannoma, neurofibroma. So Desmin, it is positive in muscle origin tumors like leiomyoma, leiomyosarcoma, rhabdomyoma, rhabdomyosarcoma. Helps to identify tumors of muscle origin. S100 helps to identify tumors which are derived from the neural crest cells like melanoma, schwannoma, neurofibroma. Now CD34, see CD34 is mostly positive in vascular tumors. Okay, this is most commonly positive in vascular tumors like hemangioma, angiosarcomas. Okay, CD34 is positive in vascular tumors, but sometimes it is positive in GIST. Okay, now if we see the histology, mostly we have spindle cell variety, sometimes it is epithelioid variety, and sometimes it is mixed variety. So spindle is most common, followed by epithelioid, followed by mixed. So histology is clear, immunohistochemistry is clear. Sometimes PDGFRA mutation is also seen as a marker. You can write PDGFRA is positive sometimes. Now the KIT gene that codes for the tyrosine kinase receptor CD117, it has two parts. See, this part is the part which is the transmembrane part, and this one is the extra membrane part. See, this is the cell, this is the cell, and this thing is the tyrosine kinase receptor. This is the extra membrane part, this one is the transmembrane part. Most of the mutations happens in the transmembrane part. The extra membrane part mutations happen less commonly. 70% of the mutations happen in the transmembrane part, less commonly in the extra membrane part. So the part which is near to the cell is called exon 11 of tyrosine kinase receptor, and the outer part is known as exon 9. Exon 11, exon 9, exon 11, exon 9. Exon 11, we have to give imatinib 400 mg. Now this is given not in every patient. See, always the preferred treatment is the tumor resection. If resection is not positive, then we give drugs like tyrosine kinase inhibitors. And if you are giving tyrosine kinase receptor, the first choice is imatinib, which is given 400 mg OD once daily. But this is effective when it is an exon 11 mutation, KIT gene. So KIT exon 11 gene mutation, KIT gene exon 11 mutation is the transmembrane part, and exon 9 is the extra membrane part, where you have to give imatinib 800 mg. So here you give imatinib 400 mg, here you give imatinib 800 mg. And if it is a PDGFRA mutation, PDGFRA, platelet derived growth factor alpha receptor mutation, PDGFRA mutation is resistant to imatinib. It is resistant to imatinib. So PDGFRA mutations, they are resistant for imatinib. KIT mutation is sensitive, PDGFRA is resistant. Again, in KIT, you have to see whether it is transmembrane or the extramembrane part that is mutated. The transmembrane part is does well responds to imatinib, but the extramembrane part you have to give higher dose. Transmembrane part is 11, extramembrane part is 9. Okay, and PDGFRA mutation are resistant to imatinib. Specifically, there is a type of PDGFRA mutation called D842V. So PDGRFA mutation D842V is resistant to imatinib. Okay, clear. So marker is clear, this is clear. Now the symptoms. Most common symptom is asymptomatic, because GIST is it grows extraluminally. It is mostly extraluminal growth. Because it is a vascular tumor, it bleeds. So most common symptom is no symptom. Most common presenting feature, if they present with, is bleeding. Investigation choice is CECT because it is an extraluminal tumor, it is going outwards. So CECT is better than endoscopy. CECT is the investigation of choice. For monitoring response to imatinib, if suppose it's a tumor which is not resectable or it's a metastatic type of GIST, then PET series is a diagnosis for monitoring. And biopsy is often non-diagnostic in GIST because it is submucosally located, and in biopsy we take the mucosal mostly because it is submucosal location, we miss very often. Now two conditions are very important in this: Carney triad and Carney complex. See, Carney triad is something which you develop on your own. Carney complex is an autosomal dominant condition. It's a genetic condition. Carney complex, it's a genetic condition. Autosomal dominant inheritance of Carney complex. Carney triad is associated with GIST, not complex. Complex is not associated with GIST. So Carney triad has three things: GIST, paraganglioma, and pulmonary chondroma. GIST, paraganglioma, and pulmonary chondroma. So GIST, paraganglioma, and pulmonary chondroma, this is seen in this Carney triad is seen in young females, and the mutation is succinate dehydrogenase deficiency. So Carney triad has GIST, paraganglioma, and pulmonary chondroma, young female HDH deficiency, succinate dehydrogenase deficiency. Carney complex is autosomal dominant. It's a genetic condition where you have cardiac myxoma. So Carney complex has myxomas, cardiac myxomas, skin pigmentation, and endocrine tumors. Most common endocrine tumor that is seen in Carney complex is PPNAD, that is primary pigmented nodular adrenocortical disease. Primary pigmented nodular adrenocortical disease. So cardiac myxoma, endocrine tumors mostly PPNAD, and skin pigmentation. In Carney complex, the mutation is PRKAR1 alpha gene. PRKAR1 alpha gene. PRKAR1A gene is the Carney complex gene. Okay. Now treatment. So treatment choice is surgical resection. That is the gold standard. No lymph node resection is needed because it is a kind of a sarcoma. So it spreads. It's a mesenchymal tumor. Leiomyoma sarcoma spreads vascularly, and then again your GIST is also mesenchymal tumor, so it will also spread vascular hematogenous spread होगा. Whereas epithelial tumors में आपको nodal metastasis मिलेगा. ठीक है. सो ट्रीटमेंट इज ऑब्वियसली सर्जिकल रिसेक्शन. हमें क्या करना चाहिए? प्रेफरेबली वेज रिसेक्शन करना चाहिए. बहुत जगहों में लिखा हुआ है कि 2 सेंटीमीटर का मार्जिन रखना चाहिए, बट इफ़ द स्यूडो कैप्सूल दैट सराउंड्स द ट्यूमर, इफ इट इज़ इंटैक्ट, you don't have to keep a 2 centimeter margin. Even 1 centimeter margin is sufficient if the pseudo capsule is intact. Avoid the tumor rupture at all cost because of the risk of seeding. Okay, so if it is unresectable, if it is a metastatic, any of the two, then you give imatinib 400 mg per day. That's a tyrosine kinase inhibitor. If imatinib doesn't respond, you give sunitinib. How do you check the response? PET CT. Imatinib is not responding, give sunitinib. If sunitinib is also not responding, you give regorafenib. So imatinib and sunitinib, they are both tyrosine kinase inhibitor, but regorafenib is not a tyrosine kinase inhibitor. It's a multi-kinase inhibitor. Multiple kinase inhibitor is regorafenib. So regorafenib is the third line drug. Okay. Done.